Everybody, welcome to Step 1 Prep. First question, 6-year-old girl presents to the emergency department by her mother due to swelling around her eyes and abdomen over the past several days. The mother mentions she recently recovered from a respiratory infection, and on examination, she has periorbital edema and ascites. Blood pressure is 90/60. Lab shows serum albumin at 2.1, cholesterol of 450, and urine analysis shows a 4+ protein with no hematuria. Renal ultrasound is unremarkable. Which of the following findings is most likely to be observed on electron microscopy of a kidney biopsy from this patient? All right, so periorbital edema, ascites, hypoalbuminemia, hyperlipidemia, massive proteinemia, proteinuria, without hematuria, normal renal ultrasound. All right, so this is minimal change disease. It's the most common pediatric nephrotic syndrome, and it presents following an infection with selective albuminuria and edema, and biopsy shows normal glomeruli on light microscopy and negative IF, and EM reveals podocyte effacement. So what about these other answers? We know the answer is A, the fusion of the podocyte foot process, the subendothelial immune complex deposition. That would be lupus nephritis, the wire looping, nephritic and nephrotic syndrome. The tram track appearance of the basement membrane, that's membranoproliferative glomerulonephritis. IgA deposition in the mesangium is Berger's disease, recurrent hematuria and post-URI and a nephritic syndrome. Mesangial expansion of the Camilston-Wilson nodules is diabetic nephropathy. That's nodular glomerulosclerosis in adults. And so really it's just minimal change disease in a child if it's nephrotic syndrome until proven otherwise. 6-year-old with puffy eyes, abdominal swelling, and lab shows low albumin and high cholesterol and massive proteinuria. There's no blood in the urine. All that tells us nephrotic syndrome, and this usually follows a recent infection. All right, so the bottom line is electron microscopy and nephrotic syndrome shows fusion of the podocyte foot processes, indicating minimal change disease. Next question, we have a 57-year-old man presenting to the clinic with a fatigue and difficulty concentrating. His past medical history is significant for recurrent gouty arthritis. His current medications include allopurinol. Lab studies reveal elevated serum uric acid level. To understand his condition, the physician explains how his body naturally synthesizes certain compounds, which are also administered in the treatment of gout. During this biochemical process, a specific enzyme catalyzes the early committed step and is subject to feedback inhibition by the end products. This process primarily controls the synthesis of which of the following? Okay, so every single molecule of uric acid in gout patients starts its life as a simple purine molecule. It's a purine nucleotide. And so here we got a 57-year-old dude who's got some recurrent gout and he's on allopurinol. And the doc is like, hey, purines didn't just come out of nowhere. The body regulates them. And the first committed step in the purine synthesis is catalyzed by glutamine PRPP aminotransferase. It's the gatekeeper enzyme. And it shuts down whenever AMP, GMP, or IMP levels are too high. And that regulation prevents overproduction of purines. But if purines builds up, they're degraded to uric acid, which drives the gout attacks. And so the process here is de novo synthesis of purine nucleotides. So amino acids, they're regulated by transaminases and feedback from the endpoints, but not linked to PRPP aminotransferase. Fatty acids, the committed step is acetyl-CoA carboxylase. It's not inhibited by nucleotides. Purine nucleotides is the correct answer. Steroid hormones is the rate-limiting enzyme would be desmolase. And triglycerides, synthesis would begin with glycerol 3-phosphate and fatty acyl-CoA, not nucleotide regulated. So every molecule of uric acid in gout patients starts with purine. All right, so here's the pathophysiology. More PRPP, more purines, more gout. Xanthine oxidase is inhibited by allopurinol. Start with ribose 5-phosphate, then PRPP is added. The first committed step is right here, and the regulation is by AMP, GMP, and IMP. So it'll precipitate in the joints and cause gout. So purine nucleotide synthesis is regulated by feedback inhibition. It's crucial in understanding gout physiology. All right, here's our practice question. 65-year-old man, type 2 diabetes, coronary artery disease, presents to the clinic with a 1-month history of worsening chest discomfort during his daily walks. He underwent drug-eluting stent placement 6 months ago. He's on metformin, lisinopril, 130/80, heart rate 78. Now he's got new ST segment depression in leads 5 and 6. What's the cause of his new symptoms? Neointimal hyperplasia in the stented artery. So the pathophysiology is you have some sort of a mechanical injury and the cytokines, and then neointimal hyperplasia, the gradual narrowing of that stented area. And then months later, you get angina with exertion-induced ischemia, which is stable. Bottom line is neointimal hyperplasia is the most likely cause of new angina after recent drug-eluting stent placement. All right, in this question, we have a 60-year-old male factory worker, persistent fatigue, easy bruising, recurrent gum bleeding. He's been a non-smoker his whole life. He's working for over 30 years in a chemical plant that manufactures plastic resins. He appears pale. Petechiae is noted on the forearms and the legs. Lab shows hemoglobin of 8.5, platelet count of 25K, leukocyte count of 52, with a prominent large immature cells noted on the peripheral blood smear. Bone marrow aspiration demonstrates an increased number of myeloblasts, and cytogenic analysis shows a T1517 translocation. Exposure to which of the following substances is most likely contributed to this patient's condition? So basically, he is a chemical plant worker with pancytopenia, gum bleeding, and myeloblasts in the marrow. So what is the toxin that caused it? Well, he has acute promyelocytic leukemia, and it's a subtype of AML. So the chronic benzene exposure is common in industries like the plastics and the resins, and strongly linked to aplastic anemia and AML. Other options are going to be associated with different cancers, not AML. For instance, asbestos, that'd be associated with a mesothelioma, bronchogenic carcinoma, not AML. Formaldehyde is a weak carcinogen that's linked to nasopharyngeal cancer. Radon is lung cancer from radioactive gas exposure, and arsenic would be skin cancer, lung cancer, angiosarcoma, not AML. So benzene destroys the bone marrow stem cells and is a notorious cause of acute myeloid leukemia. There's this dude who works in a plastic resin factory. He's tired, gum bleeding, pancytopenia. His smear shows blasts. Bone marrow biopsy confirms AML with the 1517 translocation. So it's acute promyelocytic leukemia. And there you have a risk of DIC and treatment with all trans-retinoic acid. All right, so the pathophysiology here is that you have benzene, and that exposure damages the hematopoietic stem cells. And that causes chromosomal abnormalities, including translocations like 15 to 17, and myeloid precursors proliferate uncontrollably, which leads to AML. And APL and promyelocytes accumulate and release the Auer rods, which increases the risk for DIC. That's what's going on here, folks. So benzene can be associated with aplastic anemia and AML, asbestos, mesothelioma, bronchogenic carcinoma. Formaldehyde is nasopharyngeal cancer and myeloid leukemia. Radon would be lung cancer. Arsenic would be skin cancer, angiosarcoma, and lung cancer. All right, for this next question, odds ratios. Statistical significance occurs when the 95% confidence interval does not include 1. So precision is how narrow the confidence interval is, and narrower means you're more precise. So here's a practice question. A study evaluates relationship between high sugar and incidence of type 2 diabetes. The calculated odds ratios for developing is 1.6, which of the following 95% for the OR indicates most precise and statistically significant result. Contains 1. So it's narrow confidence interval that excludes 1. And so the answer is D. Bottom line, odds ratio of 1.6 with 95 CI not crossing 1 would be significant association for what this dude has, which is type 2 diabetes. All right, this question, we have a 2-month-old with watery mucus, discharge from the umbilicus. Imaging shows persistent bowel umbilical connection. What part of the GI tract is involved? The answer is the ileum. So we have that persistent Vitelline duct connects to the ileum, and everything else is not involved in the Vitelline duct. Not the ascending colon, part of the midgut, but not connected via the Vitelline duct. Sigmoid colon is a hindgut derivative. The stomach would be a foregut derivative. Transverse colon, proximal 2/3 midgut. So the pathophysiology is you have a failure of the Vitelline duct obliteration that leads to patent lumen. I always think of severance when I see that. And the ileum remains open to the umbilicus. Then you have discharge, and there's a risk of the infection. All right, so this is kind of an interesting condition if you think about it, because essentially what's happening is babies can actually poop out of their belly button. And this happens whenever the Vitelline duct, which is a structure that's supposed to disappear during fetal development, stays open. And when it does, it creates a direct pipeline between the ileum, which is part of the small intestine, and the umbilicus. So you see a 2-month-old with mucus or watery discharge from the umbilicus, then it's a major clue that you're dealing from the ileum. It's that failure to close is the pathophysiology there. It's the persistent Vitelline duct, complete patency, and so the ileal contents leak out at the discharge happens, and you can potentially have infectious complications. Also enteric fluid loss and obstruction, things like that. And we should know some associations like Meckel's diverticulum is a partial obliteration of the Vitelline duct. So we have an outpouching of the ileum, and it may contain ectopic gastric tissue as well. And the patent Vitelline duct is the complete failure to obliterate. And the umbilical abnormalities would be like the urachal abnormalities with the bladder and the Vitelline abnormalities with the GI. And there's the rule of 2s, right? This is super important. It's going to be 2% of the population, 2 inches long, 2 feet from the ileocecal valve. And there are 2 types of ectopic tissue. A lot of 2s going on there. Bottom line, umbilical discharge in infants suggests a patent urachus or enteric fistula, most commonly connecting to the ileum. All right, in our next question, we have a 28-year-old woman who presents to the emergency department with a 4-month history of intermittent double vision and difficulty swallowing, which worsens toward the end of the day. She also reports a generalized muscle weakness after prolonged activity that improves with rest. All right, some symptoms that we need to know there. Physical examination reveals ptosis that improves after administration of a cold compress. Lab tests are significant for the presence of antibodies against the acetylcholine receptor. Very nice of them to say that. Chest imaging is performed and shows an anterior mediastinal mass. Which of the following likely is the diagnosis for the mass in the patient? Okay, so we know that this is myasthenia gravis, and that's confirmed by the ice-pack response, the anti-acetylcholine receptor antibodies, and the most common anterior mediastinal mass associated with myasthenia gravis is what? Everybody say it at once. Thymoma, right? The thymus plays a central role in the T cell education and the tolerance. And so when it forms tumors, it can generate autoactive lymphocytes, which leads to the autoimmune disorders like myasthenia gravis. Okay, how about a pericardial cyst? Well, that's also the middle mediastinum, and that's benign and non-immune related. How about the teratoma? Well, that can occur in the anterior mediastinum, but usually it's asymptomatic and there's no myasthenia gravis association. And how about the lipoma? That's rare in the mediastinum, usually subcutaneous, and it's not linked to autoimmune disease. And so that is not going to be our answer either. It's a thymoma. Well, because 65% of myasthenia gravis patients have some sort of an abnormality in their thymus. And in this case, it's going to be an anterior mediastinal mass. The most likely culprit is going to be the thymoma. So thymomas are the epithelial tumors of the thymus, and they're infamous for triggering autoimmunity, including myasthenia gravis. And so when you see myasthenia gravis and you have a mass in the anterior mediastinum, you should every single time be thinking of a thymoma. That's a rare type of cancer that arises from the epithelial tissue of the thymus associated with myasthenia gravis and other autoimmune disorders. So the bottom line is a thymoma is commonly associated with myasthenia gravis and presents as an anterior mediastinal mass. All right, here we have a 45-year-old woman with a history of chronic lymphocytic leukemia presenting with a follow-up examination. She has been on standard chemotherapy and is currently stable. Lab studies show leukocytosis, but her lymphocyte morphology is unremarkable. A third-party research trial is utilizing cultured cell samples from the patient like hers to investigate cellular resistance to apoptosis. In vitro, when the patient's lymphocytes are treated with chemotherapeutic agents known to induce apoptosis, researchers observe minimal apoptotic features. In contrast, treatment of control lymphocytes typically results in a significant apoptotic change. Genetic analysis reveals lymphocytes with minimal apoptotic change overexpress a gene. What is that gene? So what inhibits apoptosis? This is pretty much all this is saying. Long questions now just for all of that. But let's reciprocate by just explaining in depth what's going on here with this condition. So CLL cells commonly overexpress BCL2. And BCL2 inhibits apoptosis by stabilizing the mitochondrial membranes and preventing cytochrome C release. So that explains the lack of the apoptotic features in the patient's lymphocytes despite chemotherapeutic challenge. And so BCL2 is a well-characterized anti-apoptotic oncogene. All right, so our answer is indeed A, but what about the MYC protein? Well, a transcription factor that promotes proliferation, not apoptosis, right? And it's common in Burkitt's lymphoma. Mick-Burke. That's why I remember Mick-Burke. It's not classic for CLL. How about the EGFR proteins? Well, that's a receptor tyrosine kinase that's involved in cell growth. That's more relevant to the lung and colorectal cancers, not anything related to this. How about the caspase-3? Well, that's a pro-apoptotic executioner, not anti. And then the tumor suppressor that's involved in WNT signaling in colorectal cancer, like FAP, would be your APC protein, okay? So that is not the answer to this question. So they're just asking basically what's happening in CLL, and that's a disease where the white blood cells accumulate because they divide super rapidly, or rather, it's not because they're dividing super rapidly, it's because they refuse to die. So CLL is where the white blood cells refuse to die. But here the researchers are exposing lymphocytes from a CLL person to chemotherapy, and they expected to see the classic signs of apoptosis and shrinkage and fragmentation. But the cells hardly responded at all. And the reason why is because the cells overexpress BCL2. That's anti-apoptosis. So the bottom line is BCL2 overexpression confers resistance to chemotherapy-induced apoptosis in chronic lymphocytic leukemia. All right, our next question, we have a 72-year-old woman visiting the clinic with difficulty using her right hand and unsteadiness while walking, which has been worsening over the past year. She has a history of type 2 diabetes diagnosed 20 years ago, which has been poorly managed. Neurologic examination reveals atrophy of the hypothenar muscles in the right hand and inability to spread her fingers. Additionally, she struggles with balancing on her right heel and exhibits a foot drop on the right side. Which of the following pairs of nerves is most likely affected? Okay, so we're being asked about diabetic peripheral neuropathy, which tends to cause multifocal or symmetric nerve damage. And multifocal just means that it's more than one location or area of the body rather than confined to a single site. All right, so diabetic peripheral neuropathy would be multifocal or symmetric nerve damage, especially in long-standing, poorly controlled diabetes. And so this will localized to two separate nerves. In the hands, the hypothenial atrophy and inability to spread your fingers lets us know that it's an ulnar nerve palsy. And in the leg, that's foot drop, and so there's difficulty walking on the heel. That's going to be ulnar. Inability to spread the fingers, that's the interosseous weakness of the ulnar. So you check it out, ulnar. Foot drop is paralysis of the dorsiflexion. The deep fibular is a branch of the common fibular and has a motor in the anterior compartment of the leg, the dorsiflexion, and the lesion is associated with the foot drop and the high stepping gait and the loss of sensation between the first two toes. Now, diabetic neuropathy is where you have a microvasculature injury to the nerves, and that can cause neuropathy multiplex. Here we have a 28-year-old man presenting to the emergency department with a history or a severe headache and muscle aches and fever of 102.2. Symptoms began 3 days ago when he was on a hiking trip in the Pacific Northwest. Physical exam reveals conjunctival suffusion and calf tenderness. Initial laboratory tests show elevated liver enzymes and mild transaminitis. Blood cultures are pending. Which of the following infections is caused by an organism most similar to the likely causative agent in this patient? All right, so he has leptospirosis. It's a spirochete infection. All right, so this is leptospirosis, which is a spirochete infection. And they're asking the similar morphology here. So it's similar to Treponema pallidum, which causes primary syphilis as our answer. So the answer is a C. It's not cat scratch disease. It's a gram-negative bacillus, not a spirochete. Gonorrhea, Neisseria gonorrhea is gram-negative diplococcus, not a spirochete. Rocky Mountain is an obligate and intracellular coccobacillus, so different, and tetanus as well as a gram-positive spore-forming rod. Whereas syphilis is a spirochete that causes or that is associated with Treponema pallidum. So leptospirosis has that in common with Treponema pallidum, which is the spirochete that causes primary syphilis. So the bottom line is leptospirosis, indicated by fever, conjunctival suffusion, and muscle aches, is often linked to exposure in freshwater environments. And it's also important to know that it shares that commonality with primary syphilis. Leptospirosis and Treponema pallidum both have that spirochete morphology. And the pathophysiology is where you have exposure to contaminated fresh water. So leptospira enters via the abraded skin or mucous membranes, and then you have flu-like symptoms, myalgias, especially the calves, and conjunctival suffusion. And then later you can have jaundice, azotemia, and hemorrhaging due to the hepatic and renal involvement, right? So the spirochetes are those hook-shaped ends like leptospira, and the freshwater exposure is the key clue there. Also, especially in the calves, they have the fever, the headache, and the myalgia, and the conjunctival suffusion, the redness without the exudate, and the history of exposure to contaminated water while hiking. Didn't really focus on that there, but the thin, spiral-shaped spirochete bacterium has the hooked end since transmitted by water with animal urine in it. Hopefully this has been a nice little step 1 study session, and we'll see you guys in the next video.